Hey, how many you all have joined? Can you pass a message? We can start little early.
So we'll ask others to join quickly. Wait.
It's going to be frightening. You can see that. Yeah, dirty anatomy, all that will be there again. But I'll try to keep it a bit interested by talking towards the clinical sense of it. So it's a big lecture. So I think you all have it's full board now, right? All have joined. Am I right? It's full board. Am I right? All have come.
Yes, sir. You can start the lecture, sir.
Right. Right. Beautiful. Yeah. Thank you. So today we are going to start a little bit about clinical anatomy, pelvic anatomy, anatomy of the pelvis. All are the same, right? So why it is important? Because gynecology and obstetrics deals with the pelvis and then the surrounding structures, which are constantly being subjected to surgery by even by the junior people. Like say you are as a medical student, you are doing an episiotomy and suturing it, right? So just before you qualify your basic MBBS, you need this pelvic anatomy. So this is one reason why I think it's very, very important, right? So not only obstetrics and gynecology, emergencies deal with pelvic anatomy. The common obstetric and gynae procedure need a thorough knowledge about the anatomy. So this is why one point that I want to highlight. Right? Then certain procedures like episiotomy, right? Then regional anesthesia, you want to put the forceps to deliver the baby. How would you give the local anesthesia? And then if you want to deal with the cervix or something, and then how would you do the paracervical nerve block? Because if you do dilatation of the cervix and all that without giving a block, then that the patient will go into severe neurogenic shock. Then that kind of a situation to be, if that kind of situation to be avoided, you need to acknowledge how we give the paracervical block, what are the nerves involved and all that. And then pudendal infiltration, common was done in the past, where we focus the direct the needle towards pudendal nerve block. And perineal infiltration is very simple. Just get into the perineum, put the hand in the fingers in the vagina, separate it and inject all over the perineum. That is perineal infiltration. And more advanced would be pudendal nerve block and the caudal block. And then when everything is not right, bleeding after cesarean section or delivery, the surgeon should know how to ligate the uterine artery. And if everything goes wrong, then you need to ligate the internal iliac artery without tying the external and common iliac. And then having a ischemic ring. Right? So these are the surgical challenges from minor to major left in front of a practicing obstetrician and gynecologist. What I mean is obstetrician and gynecology is not only the consultant, the doctors who are dealing with obs and gyne. Then for basic procedures like how would you take a pap smear, how would you insert a pessary, any other gynae minor surgeries, you need to know the anatomy. Right? So we start with the bony pelvis, the boundaries of the pelvis. The pelvis starts from the pelvic cavity starts from the pubic bone and then the sacral promontory and ala of the sacrum, iliopectineal line, then pubic symphysis. And very importantly, there is an angle. If you keep the pelvis, if there is an angle between the horizontal plane, there is an angle between the plane of the inlet with the horizontal plane it's around 60 degrees. If you look at the inlet, it's not like a bucket. It's just inclined bucket kind of thing, 60 degrees angle. Right, so that's one important point I want to highlight. Right, so this is what I have said. Yeah, this exactly shows the horizontal plane, the plane line, and then the inlet is in a 60 degrees angle. Right, so again you can see, if you look at the very important this little diagram. So you define the pelvic cavity. This is inlet. The red line goes to the inlet. Remember everything. And then this is mid cavity. Right? The ischial spine is right. Sacrospinous ligament. Right? And this is the measurement that we take to assess the mid cavity. Inlet, you know, this is the measurement from do a VE, and if you can feel the sacral promontory, you know it is less than 11.5 centimeters. But if you can't feel it, that's the dimension we want. You put your fingers in and then go to the sacral promontory. Generally, it should not be felt, even with the longest fingers. But if you feel it, you know there is a problem with the inlet. So that is how you assess the inlet. And then the mid cavity is the sacrospinous ligament and then sacrospinous process. Ligament and sacrospinous process. And then you may appreciate this is the outlet. What I drew from the coccyx, sacrotuberous ligament, ischial tuberosity, and ischiopubic cranium. So that forms the outlet. So inlet, mid cavity, outlet. Because these are constant questions that will be questioned during your viva and or day-to-day all your obstetric. How do you assess the inlet? How do you assess the mid cavity? How do you assess the outlet? Because that is where the baby is going to go through. So let me come back in the next slide. Pelvic outlet contains pubic arch, ischiopubic rami, ischial tuberosities, sacrotuberous ligament, and the coccyx. And the angle between the plane and the outlet and the horizontal is about not like 60%, outlet is about 15%. Right, so remember all these can be your MCQ. Able to examiner might put these MCQ as MCQs. Outlet lies 15 degrees to the horizontal plane is the correct answer. Right. So this is the outlet once again. Same diagram. Why I repeatedly tell about it? Because this is what you are going to assess as an intern house officer when a woman comes for labor. Whether this woman has an adequate pelvis to deliver the baby. How do you assess the outlet? Right, so you will come to know, right, when you go to the final year, the professorial, how we do assess. Probably, I hope that even that time it will be a Zoom demonstration, but it doesn't matter. Keep yourself calm and quiet. Right, these few years will go through. Your education is not interrupted. We are doing everything to continue the course and that we make sure you pass out at the correct time. Right. So this is how you do the assessment, right? So you put your fingers into the vagina, right, and then assess the inlet, then mid cavity, and then outlet. Different techniques. Right. Okay. Boundaries and shape of the birth canal, pelvic inlet, transverse diameter is more than the anteroposterior diameter. That is because the head enters into the transverse position. We can so can you all see me? So that is your baby, right? So this is the head. Right, so pelvic inlet, the baby's head goes transversely, and then it comes out antero-posterior. It goes transversely and comes out antero-posterior. This is why pelvic inlet has a wider transverse diameter than the AP diameter. And if you look at the outlet, you can see at the bottom transverse diameter is less than the AP diameter. So that means AP anteroposterior diameter is more than the transverse diameter. That is why the baby's head comes in anteroposterior direction. There is a rotation taking place. Head enters like this and then delivers like this. Right? So very simple, right? God is not magic, it's something simple, right? So I want you to go through all these posterior wall sacrum and the length, anterior wall pubic ramus, widest plane between S2 and S3, and that forms the mid cavity, right? And narrowest plane is at the level of the scale spine and inferior border of the pubic ramus, least roomy, therefore frequently cite for problems. Mid cavity arresting is very common because that is the least roomy point. Right? Upper part of the mid cavity is wide and the lower part of the mid cavity is very narrow, and that is where the deep transverse arrest and the rest of the fetal head, all that can take place. And then pelvic outlet is straightforward. Transverse diameter is less than the AP diameter. AP diameter is more. Let's look at simple surgical procedures that you do. It's a deliberate cut. The feature. forceps, vacuum, it could be shoulder dystocia, breech delivery, where you have to put your hands in. In that situation also, you prefer to do an episiotomy. So that's a well-known indication, large baby tight perineum, and any operative and any manipulations in the vagina is indicated you would like to do a episiotomy. It's a deliberate cut that is made in the perineum after local anesthesia. And also it is done to cut short the second stage of the labor, like in heart disease, fetal distress, and prevent head compression, like in preterm babies, to prevent intracranial hemorrhages. Preterm babies' head skull is very like kurumba, very soft. It can compress and decompress, and it can tear all the veins and inside. Therefore, you don't want that the perineum to compress and decompress. Therefore, you make a cut. So, episiotomy is indicated for preterm deliveries. Right? Very important. If the baby comes in breech, it's a must to have a episiotomy. Right. Episiotomy should be done. Now, this is a deliberate cut, I said, done to facilitate the delivery of the baby, and it's indicated in large babies, tight perineum, breech, shoulder dystocia, and operative manipulative deliveries, and then shorten the second stage, and all that good things are there with the use of an episiotomy. But very important, you time it. If you cut it early, it will bleed. Patient will bleed about 500 ml before the baby is born. So blood loss will be more. If done too late, it's not going to suture. If the baby's head come halfway, and there is no point you are doing it. It can lacerate the perineum. Baby has come without a proper. You cannot suture many lacerations. So better to suture one clean episiotomy. Right? So therefore, it has to be made at the correct time. Right? So perineal body, and thereby fails to protect the pelvic floor. Bulging and thin perineum. If you see the delivery, you will understand head comes, and then when the head crowns. Crown means that the head comes down and does not go back. That is the time that you make the episiotomy. It's the ideal time. So once again, I have told you this, while an episiotomy is done, the advantages, it's made to clean and controlled deliberate incision, easy to repair, and it heals fast and better. Then, if the episiotomy is not done, then what you might end up in multiple lacerated tears. And a bone bag vagina is not the place to have that kind of experience, right? So it's like a bomb. It tears everywhere. So therefore, you would prefer to suture the episiotomy and sort it out. Timeless, the episiotomy prior too long or too much stretching prevents the strength of the pelvic floor, right? Too long and too much stretching, right? So too much stretching preserves the strength of the pelvic floor. Right? That is also very important. If the episiotomy is not done, it really stretches the pelvic floor, and subsequently that woman will have a prolapse kind of a thing. So episiotomy is a timely cut that will prevent those things also. Right? Sometimes the laceration, which I have said, can extend to the anus and surrounding structures, can lead to increased bleeding, right? And also episiotomy provides the shortening of the second stage by reducing the bearing down effect, which may be beneficial for mothers with impeded cardiac output, respiratory disease, very high blood pressure, where straining should be minimized. Also, it is informing patients with intracranial injuries and preterm babies that it protects the compression decompression injury. And also fast delivery, which reduces the fetal asphyxia and acidosis. So this is something that I didn't like very much as an undergraduate. I hate anatomy. I don't know how I became a surgeon. But that's a good example for anyone who has not done dissection. Still you can become a surgeon, and my surgical skills are very well discussed, and I'm very proud that I'm considered as a good surgeon, but I never done my anatomy and dissection very well. I was just an average body. You know? Still I have the little fear when I look at this diagram, oh, what am I going to say, right? But easy, if you look at it, the perineum is like a muscular diaphragm, right? So you have, if somebody asks you, close your eyes, can you describe the pelvic floor? You say the pelvic floor, it's like this, children. Pelvic floor is like the floor you sit. You sit on a chair, and you are uterus, and your supports are the chair are the uterine supports, and chair supports on the floor, which is the pelvic floor. So that is how I tell everyone to understand the pelvic perineal supports. You are the uterus, and your hands are the soft uterine supports, and your legs of the chair will be your pelvic perineal supports, and the floor which the chair and you sits on, it's the pelvic floor. That is the exact approximated example that I can tell you about the female perineum and the supports. Right, so this is the concrete flow that I am describing, and through the concrete flow, the levator, you have the tuber rectalis, and then the tuber vaginalis, and then the tuber urethralis. Right, little muscle fibers go around each orifice, rectum, and then the vagina, and then the urethra. Right? So all these are levator muscles. They are originating from the fascia of the inner side of the pubic symphysis, right? And then you can see upper side also there are pelvic floor muscles, and if you go deep into the muscle, you see the vestibule bulb which supplies the secretion to the vagina, very important females, right? And then the anus, the role of the tuber rectalis, very important, right? So I'm not going to talk a detail about it, but just get this thing into your head and the example that I gave you. Right. And if you look at the this diagram, I'm talking about the anterior and posterior. If you look at from the top, you saw the bottom, the levator line, and then in the top you get again the fascia, and in between you have superficial perineal space and the deep perineal space. Very important, because through these the nerves and the blood vessels traverses. And pelvic surgeons, all life is dissecting on this. Api hamadama we used to cut this fascia, all that, and then suture, repair, right? Right? Sometimes we might anchor the vagina to the uterus, ischial-spinous ligament. There are surgeries, right? It supports the sagging vagina to the ischial-spinous ligament, right? So all that you need a detailed knowledge about the pelvic anatomy, right? Look at this urogenital region, superficial perineal space of the pouch and deep perineal space of the pouch. Chief neurovascular bundle of the perineum is in the fascial tunnel. That's called pudendal canal. Pudendal nerve is the chief nerve which supplies the vagina. All your exotic pornographic sensations, all this world, women and all their sexuality is brought by the pudendal nerve. If a woman doesn't have a pudendal nerve, that woman will not never have a sexual pleasure. So respect the pudendal nerve. Boys go and worship this. Very, very important. Even for men, that's the most important nerve in that area. And then internal pudendal vessels, which supplies again the perineum, right? So we'll come to that little later, but chief nerve of the perineum is pudendal nerve, and internal pudendal vessels are the principal supplier. And all these canals are lies in the lateral wall of the ischiorectal fossa. Right? We will come to that. Okay. Same the perineal spaces, fascia and the muscles, and in between you get the nerves going. Right? So perineal membrane and deep perineal pouch. So this is the deep perineal pouch and this is the perineal membrane. So there is opening for urethra and then this is the membrane. So this one generally we cut during any surgery to cystocele, bladder and all that. This is the space we get into. Right, but just know there is a perineal space in the anterior triangle of the vagina, right? And then male, as you know, it's a simple thing, you know. Male have penis compared to women, so male urogenital triangle is different. It has external genitalia, penis and external structure, so it's little different to women, but it's the same thing. Superficial fascia of the penis and then deep box fascia of the penis and then the ligamentous support. Same thing are embryologically modified in men. So if you look at the structure of the male penis, internally, you know, your erectile tissue and then the penile urethra begin at the superficial perineal pouch as a membranous urethra and penetrates into the urogenital diaphragm. And it receives the ducts of the bulbourethral glands and mucorethral glands of litter. And then the scrotum suspended from the male perineum, because the temperature is going to be a little less than the body temperature for the testis. So it has come out embryologically, and scrotum contains testis, and from the testis the chromatic cord comes up. Chromatic root along with the chromatic cord, it provides a route for neurovascular and ductal communication between the scrotum and abdominal pelvic cavity. It goes through the inguinal canal, and then it comes out the internal, goes in the anterior space and joins to the prostatic urethra to the prostatic urethra. So if you remember IBS's anatomy, that is what I just want to remind you. Right, so this is how you do an episiotomy. You infiltrate the perineum and then make your cut. So this is how you infiltrate, inject, put the needle in and withdraw it to see whether you are inside a vein. If you are inside a vein, go deep or pull it a little up and withdraw again the syringe and see the blood should not come in. If the blood comes in, then you should not release that contents into the blood vessel because it can go direct to the heart and cause arrhythmia. Right? So therefore, very carefully you have to withdraw and see when you are giving lignocaine. And then once the lignocaine is given, leave about 2 to 3 minutes and then you can make the cut. So this is how you make the cut. You put your fingers in and then from the vagina at the 8 o'clock position. From the vagina, 8 o'clock position, you cut. It's called mediolateral episiotomy. Right. So then these are typical questions that we ask. What are the muscles that you cut in a typical episiotomy? Obviously, superficial transverse perineal muscles, deep transverse perineal muscles, bulbospongiasis muscle. If the episiotomy is too deep, can cut the levator line muscle as well. So depending on if there's a, these are the layers of the pelvic floor, you look at it. So depending on the deep episiotomy can even improve the levator muscles. So we are not structures to be cut in different types of episiotomies. So you see what we commonly use the episiotomy starting at the 8 right. So we cut at the 8 o'clock position. So that's called mediolateral episiotomy. Mediolateral episiotomy. This one. Lateral is completely lateral. Mediolateral and median episiotomy. That means at the 6 o'clock position if you cut, that is not commonly practiced currently because you see it can extend into the anal sphincters. The whole idea of giving episiotomy is to prevent the anal sphincters getting torn. So then therefore my best advice, though it is mentioned in the slide, to avoid the median episiotomy. But then the mediolateral seems to be the common and popular choice among a lot of doctors who are practicing obstetrics and gynecology. And then very important thing, you all know this, blood supply to genital organs, right? I hope that you will not get a question like this, but still it's a potential question, especially for postgraduates who want to become obstetrician and gynecologist, right? So this is something that's very important to know, blood supply to genital organs. So artery of the pelvis is your internal iliac artery. Artery of the perineum is pudendal artery. Right? Artery of the pelvis is internal iliac artery. So it's a branch from the common iliac, and where external iliac artery goes and continue at the edge of the femoral canal to become the femoral artery, and internal iliac artery supplies the perineum. Sorry, pelvis and the perineum and all the structures. So one of the branches is the superior gluteal artery, which goes back to the goes back and supplies the perineum. Sorry, the buttocks. And then the anterior division, which supplies the uterus, superior middle vesicle, uterine artery, middle rectal artery, pulmonary artery, all that is supplied by the anterior division. If someone wants to stop the uterine artery bleeding, then the best advice would be tie the internal iliac artery anterior division. Then tying the common internal iliac artery best thing would be to type the anterior division. Then the person will not feel the gluteal ischemia. Gluteal ischemia is something very nasty. If you tap on that woman's back, she gets current because of the ischemia. So we generally avoid that. But after all, currently we do the internal iliac artery ligation using white film. After 7 days, when it's job done to achieve hemostasis, the suture will get dissolved and the vessel will be reconversed. So no permanent damage by tying the internal iliac artery. So remember, this is the blood supply to the perineum and the pelvis, right? So the pudendal artery is the artery of the perineum, that's called internal pudendal artery, and internal iliac artery is the artery of the pelvis. Okay, the branches of internal iliac artery, some silly thing, make a mataka tiagana, iteradi amari. So I recommend you to know superior vesicle, inferior vesicle, middle rectal, obturator. Some inherit money, others inherit insanity, such is life. So I think it's difficult to remember that, but I have put it. You want to take it. Okay, right. So remember, these are the important branches of internal iliac artery. Once again, let's supply to the genitalia. If you look at the ovary, it's supplied by the ovarian artery that rises directly from the aorta. It passes through the broad ligament. So after supplying there's a vascular arcade, and then there is a uterine artery which starts from the internal iliac artery, and there is an anastomosis between this, and the uterus is supplied by both ovarian as well as uterine arteries. Not only that, you can see it's supplied by the reproductive artery and vesical artery and all that. So all the arteries in that area supplies the uterus. Uterus has an anastomotic supply from both ovarian and uterine arteries, both vessels running in the broad ligament. Right. So then, summary of that blood supply to the pelvic organs: ovary, ovarian artery, origin from aorta. Ovary also supplied by the uterine artery, originate from internal iliac. Fallopian tube supplied by ovarian and internal iliac again. Uterus is supplied by uterine and ovarian. And then next one. The vagina is supplied by the vaginal arteries, which is arising from pudendal arteries and all that, arising from the internal iliac, uterine artery, again from internal iliac, and internal pudendal, middle rectal, and all that. And perineum, vulva, is mainly supplied by the internal pudendal and external pudendal, which is a branch of femoral artery. Then ureter, all the segmental blood supply from the area where it traverses from renal artery, ovarian artery, uterine artery, superior vesicle, inferior vesicle, and bladder is supplied by the superior vesicle and inferior vesical artery. Then urethra, inferior vesicle, internal pudendal, sigmoidal colon, left colic, which is starting from the inferior mesenteric, and the rectum is supplied by superior rectal, middle rectal, and inferior rectal, obviously all the rectal vessels. So these could have been MCQs in the IBSs. But somebody wants to do gym and ops, my best advice is to keep this lecture because this is very basic pelvic anatomy. Why we should know about this blood supply? PPH still is the common cause of maternal deaths in Sri Lanka and developing countries. And if you know this anatomy, it can be prevented by early recognition and intervention. Intervention techniques all deal with anatomy of the blood vessels. While primary PPH can occur in spite of active management of third stage of labor, maternal death from PPH is an inexcusable. ගහනවා පුතා අපිට මේක අම්මා කෙනෙක් මැරුණොත් බීඩින් වලදී ආයෙ වියෝජිත යන්න වෙන්නේ නැහැ වැඩට. ඒක වෙන තරක් තමයි ට්‍රාන්ස්ෆර් යන්න වෙන්නේ. Because it's a social tragedy. So there is no excuse for us. We must absolutely clear our minds what course of action to be taken when we are confronted with a patient with PPH. So this is the big idea. Now if you look at next slide, what I do is to prevent PPH. I can do either ovarian artery and uterine artery, both I can do. If that fails, I can go for internal iliac. Definitely with internal iliac ligation, you will control bleeding 100% because you remove that main supply. The importance of this arterial ligation is when you tie the artery, it doesn't stop the blood supply to that particular organ. Because there are so many collaterals, the trick hammer effect of the arterial flow, trick hammer effect, spurting effect is lost. So the arterial supply become almost like a venous, non-pulsatile. So as a result, the clotting can take its action and form a stable clot. Otherwise, what happens with the trick hammer effect, the clot gets dislodged. Again, it's not bleeding. Until the blood pressure drop, then there can be clotting. But then the blood pressure drop can lead to death of the patient. So, right, therefore, so to make the arterial circulation a venous, we tie different blood vessels. Then coming to internal iliac ligation, it's technically difficult and is something every obstetrician should be very thorough with. Should not be undertaken without adequate training, indicated when the patient is hemodynamically unstable. I really remember when I was a registrar, my boss could not. No, my next ward boss. My boss could do it. My next ward boss could not tie the internal iliac artery. So he can only shout. I can remember he is a man who shouts a lot. People who shouts a lot lacks lot of skills in their life. You can point out people who find out minor offences in the students, sabotage and hammer them are the ones we have deficiencies in lot of things in their life. So like this man also, he shouted at me, so bring the vascular register. So I called the vascular registrar and I said, bro, I need your help. We need to ligate the internal iliac. So he is telling me, where is the internal iliac? Right? So then I got fainted. Vascular registrar asking me, where is the internal iliac? So he probably could have been in this lecture today. Then he said, Malli, very sorry, it's my first day today. So there, what can you do? We call another consultant and got it done. So this is the important thing. It's a very expertise job, right? And it success rate of the internal ligation in my series, I have done many, is more than almost 100%. And it prevents a hysterectomy about 50 to 60% of the cases. Right? So it's definitely indicated if the patient's hemodynamic stability is somewhat compromised, and unstable and to safeguard the patient's life. Difficult procedure, sometimes during the process you will cut the vein, you can kill the patient immediately. So this is where it's very important. My last internal ligation was June 2021. One of the other consultants at Navaloka called me. I did it for him. Okay? So it's 5 minutes job for me. It's very, very reassuring, and patients are living because of this little technique. Very, very important. If you look at the technique, it's like this. You dissect the area of the bifurcation of the common iliac artery and then pull the external iliac artery with a rubber. And then that highlights the internal iliac artery, and then you pass a right angle clip. Very easy. So this is what the second part of the diagram shows, a right angle being passed under the internal iliac, and then you, from the tip of the artery, you pull a thread and then just tie. Just tie. That will stop. When you are tying, it's very important to let the anesthetist feel whatever the bad reason. If you tie the external iliac artery, that limb will need to be amputated. Therefore, you just make sure that your tying will not interfere with the limb pulse. So when I do it, I generally tell, I know I'm doing internal iliac, I can see the external iliac, but still I check the pulse of the limb, because sometimes there can be big collaterals from external to internal. So we never know what these people are. Therefore, I always check the pulse of the particular limb side of the internal iliac ligation. Right, so then we come to the next part, pain pathways in labor. So why you should know the anatomy of the thing. If you look at the uterus, fundus is supplied from T10, that is the pain, labor pains. First stage is where the womb is contracting. Second stage where the baby is coming from the vagina. So first stage you need the T10 to L1 block, and then at the time of the delivery, say the mother can say, look, I can bear down my labor pains, but I should not have any pain during my birth passage. So the second stage is exclusively sponsored by, the pain is sponsored by S234, the parasympathetic nerve fibers, and which goes to the pudendal nerve. So you can see now a simple pudendal block will help the mother a lot in preventing the putting the forceps, all that. This is the most important item. Right, so you got this diagram, upper part for the labor pain, lower part for the delivery. Good. Right, so then these are the nerves, ilioinguinal nerve, genitofemoral nerve, branches of the pudendal nerve, and then the inferior hemorrhagic nerve. And then next is labial perineal block. Very simple. This is what is handy for our junior house officers. Needle එක අරගෙන අතර පැත්තට විදින එකයි තියෙන්නේ. චුට්ටක් ඇතුළ ගන්නවා. Then you aspirate for blood. If there is no blood, you inject to 1, 2, 3, all these areas. That will block all the ilioinguinal, genitofemoral, branches of the pudendal nerve, ischial tuberosity, and inferior hemorrhagic nerve. So these are the nerves that will give the extreme pleasure for women, but these are not important during the childbirth, right? So we block all of them by giving this, and then we make a deliberate cut and then deliver the baby, right? So how we give a pudendal block is next. radial perineal block, extensively used for episiotomies, forceps and deliveries. 10 ml of 1% lignocaine is used. Perineum is infiltrated in the fan-wise manner, starting from Q-shape, and then each time aspiration is done to exclude blood in the navel. Single side for an episiotomy and both sides for a forceps delivery. And then paracervical block. This is where we want to deliver the baby to numb the cervix. So you can see the pelvic plexus. You pass the finger into the lateral fornix and through the finger you guide the needle and infiltrate the uterine plexus. That's paracervical block. A long needle, 15 centimeter or more, is passed into the lateral fornix at the 3 and 9 o'clock positions. 4 to 5 ml of lignocaine with adrenaline is injected to the site of the cervix. Why adrenaline is introduced, children? For the anesthesia to stay longer. If you put adrenaline, it raises spasms. So it is not it doesn't get absorbed to the bloodstream. So anesthesia remain in that area longer. So this is why lignocaine preparation sometimes comes with adrenaline. You have the advantage of less bleeding because of the adrenaline, as well as more duration of anesthesia because of the vasoconstriction. So this paracervical block can be used for DNCs in general anesthesia for unfit patients. So when I was my first appointment at Balapitiya, I did not have an anesthetist. I never grumbled. I wrote to the ministry and I started all my cases in local. Paracervical, all the operations were done except major hysterectomies until the anesthetist came. We did everything. Right? So surgeon should not be left alone without an anesthetist if he knows about these blocks and these anatomy, how the blocks are given. It's a must. Then, very important to know about the pudendal block. Again, there's a particular needle that is used. It's called pudendal needle, and pudendal block most used for forceps and vaginal breech deliveries. Simultaneous perineal and vulval infiltration is needed to block the perineal branch of the posterior cutaneous thigh. So we had a problem. Pudendal nerve only is not sufficient. You saw its multiple nerve supplies. So this is where it can fail. It can anesthetize the middle and the upper lower vagina, but when it comes to the perineum, posterior cutaneous nerve, the thigh and all that are not the branches of the pudendal. Right? So they need to be given by another perineal infiltration. So this is why it's far superior to give and simple to give the perineal infiltration in a fan-shaped manner. Then it is a technique if someone knows it. Right? So I don't think you should know about it. And I am sure everyone likes this topic. More than anatomy, I am sure every student is very, very knowledgeable about the lymphatic drainage. Honestly, I am still as good as you are about the lymphatic drainage. But I know one thing, if someone asks me about the lymphatic drainage, I always say lymphatics are accompanied with the respective blood vessels which supply that particular organ. And then it drains to the regional nodes, and from the regional nodes it drains to the para-aortic nodes and all that. No? So from the regional nodes it goes to the para-aortic nodes. So that's all you have to say, right? It's very important that you have a good knowledge because lymphatics are very important because you are dealing especially with gynecological malignancies. Right? So lymphatic drainage of the pelvic organs, you can see internal iliac nodes, then the common iliac nodes, and then the aortic nodes. You can see all that, right? Cervical nodes. Right? So all these will contain pelvic nodes, all going into the common iliac nodes and then to the aortic nodes. Next diagram. You see the aortic nodes, external iliac, internal iliac, all. Right? Then the sacral nodes. You can see some of the parts of the uterus can be even drained into the superficial femoral nodes, right? So inguinal nodes, upper part of the uterus especially, right? So that is also important. So most of the lymphatics go into the regional nodes, and some of the lymphatics can go into the inguinal lymph nodes through the superficial femoral vessels. Right, so lymphatic drainage of the pelvic organs, ovary to aortic nodes, fallopian to the again lateral aortic nodes because ovary and fallopian tubes near together, and then upper part of the tube and the fundus of the uterus can go into superficial inguinal nodes, and fallopian tube also can go into internal and external iliac nodes. The uterus body, external and internal iliac nodes, and upper part of the uterus can go into superficial inguinal nodes and lateral aortic nodes. From the cervix, again external and internal iliac nodes, arterial nodes, sacral nodes, very important. See your cervix, you know all these. Right? And then upper vagina, external and internal iliac, arterial and sacral. Lower vagina, of course, to the superficial inguinal nodes. When it comes to the organ, vulva, again superficial inguinal, vulva is outside the vagina, and sometimes internal iliac, ureter, again the regional lymph nodes, internal iliac, external iliac, lateral aortic, where it comes from. And bladder, exclusively internal and external iliac nodes, and urethra, internal iliac nodes. And just to know about the sigmoid, aortic, upper rectum, the same, and lower rectum, internal iliac, and anal orifice, superficial inguinal nodes. Then coming to the final part of the lecture, cervical smears and colposcopy. Colposcopy is the equipment which magnifies the cervix and see the vascular pattern and everything of the cervical canal and sperm-colon junction and epithelium, all that, right? So we use different stains and identify the abnormal cells. Main aim of the colposcopy to see any cancerous area and then take a biopsy. That is the main advantage, right? So then puberty and elderly, the sperm-columnar junction is up because of the lack of estrogen. But when at the puberty, rise in estrogen level, there is a tendency for the sperm-columnar junction to come down, and eversion and enlargement of the cervix and extrusion of the sperm-columnar junction and the ectocervix. During the pregnancy, when it's taking estrogen pills and all that, same type of changes occur. So just to know, there is a place called sperm-columnar junction which can go up, like in menopausal lady, when there's low estrogen, pre-pubertal. When they become pubertal, the estrogen levels are high, it comes down, and in pregnancy and estrogen pill and all that, it comes further down. Right? So this is the area which undergoes sperm-columnar junction is the area because there's rapid process of metaplasia, and that's the site that can lead to intraepithelial neoplasia and cancers. Now people know that this intraepithelial neoplasia is as a result from what? Can someone tell me what virus caused the intraepithelial neoplasia? එමන්න මට මේකක් අත්දලා මම ටිකක් නතර කරන්න ඕගොල්ලෝ නිදිත් ගන්නනේ. ආවොත් බැරි. මේ මවුස් එක වලින් කරගන්න. Open my mouse. Can you hear me?
Yes, sir. We can hear.
What will happen to this thing? What will happen to what is the virus which is responsible for this?
HPVs.
Very good. Do you have a girlfriend? So how would you prevent your girlfriend getting this problem?
No, sir.
You heard the vaccine, HPV vaccine, but before you have any sexual activity, my dear, if you have any sexual activity, it may be too late, right? So when you give that vaccine, you don't have to do the pap smears and all that. You know, the commonest and known reason for cervical cancer is HPV virus infection, and it dramatically almost reduces the cervical cancer incidence to 0. So remember that. Okay. Right. So, more slides. So this is the sternum junction. And this is what is the, how do we take this picture? What is the instrument we use? Colposcopy, right? Now, this is the abnormal area in the colposcopy, right? So we apply acetic acid, and this is the abnormal area which can develop into cancer. Right. Following the climacteric, that is your menopause, when the estrogen level falls, cervix shrinks, drawing the squamous columnar junction into the cervical canal. So this is why when you do a pap smear, you should use a cytobrush and do it little deep inside the cervix, then only you get the squamous columnar junction. So this concludes the anatomy lecture. I hope that you understood anything out of this. Do you have any questions? You can SMS it to me, you can chat it. Any silly question is alright, because you know I will not recognize you by name, so that's okay. So no question means that you are alright, knowledgeable, right? Vagina and penis and all that. I had the luxury of teaching you that, and I'm very proud about it. So learn these things. Okay, we'll call it a day. Thank you very much for joining me today. So when is the next lecture? Can the student monitor tell me the next lecture of me? Who is the monitor?
So next lecture is on Friday, sir. Placenta membranes, cord structure and function.
Do you have a bed and a mat? Other lecture, I can guarantee absolutely you fall into a deep sleep. Right? Foundation of the matter, know what to do, you can never teach you. So how would you like your embryology in IBSS? I'm sure you are very learned about your embryology. just to enjoy the skills on Friday. Friday, what time, dear?
2:15, sir.
2:50.
Yes, sir.
ඒකත් මේ වෙලාවට 3:15 වගේ දාගමුද?
Okay, sir.
Because you know I work. I'm the chairman of the NRC. I have to work there, and then when I return only I can teach you. So kindly adjust your time with someone, and then I will start it by 3:15. That's perfectly alright for me.
Okay, sir. Okay, sir.
Okay, have a nice time, stay safe, don't go out. 15 minutes into the get 10 minutes, stay out for about 7 days and come to your home, wear a mask. You need to wear a mask because things are going to be very, very critical. You all had your vaccinations done, right? I have done it with Vajira, offering you the second dose. I hope you all have got your vaccine, right? Has anyone who has not had the vaccine? Right. I'll see you.